This week for our HESI review, we are going to cover respiratory disorders and cardiac disorders. So starting with an overview of normal heart rates and respiratory rates for our kids, our newborns are obviously going to be faster, that 100 to 160 for heart rate, 30 to 60 for respers. As we reach a year, we start to decrease. Our toddlers are going to be in that 80 to 130 heart rate with 20 to 30 respers. Then our preschoolers are going to decrease just a little bit more, 80 to 120, 20 to 25 for respers. Then once we reach school age, we should be hitting close to adult vital signs. So heart rate's okay to be 70 to 110. Respers are going to be 18 to 22. And then by the time we're an adolescent, we've hit that adult milestone. So our respiratory disorders are the primary reason that most of our kids come into a medical facility. So they are frequently tested on HESI and NCLEX. So make sure that you know these vital signs as well as the signs of respiratory distress for these patients. So we just reviewed the vitals. Now we're going to review those signs of respiratory distress. So anytime that we don't have enough oxygen going to our brain, we are at risk for changes in our level of consciousness. So we may see restlessness, we might see irritability, being lethargic. We're going to see an increased respiratory rate and heart rate. We can see sweating. Those visible signs of respiratory distress, that flaring of our nostrils, retractions anywhere in between our ribs, above, below, anywhere along that chest wall. We can also hear grunting or any abnormal breath sounds or lack thereof, obviously an indication that we're not moving air. In addition to the flaring nostrils and retractions, we can see accessory muscle use and head bobbing. They look like a little bobblehead when they're trying to breathe, using their belly muscles, all of their body to try and get that breath in. We can see color changes. They can be pale, they can be cyanotic. And then if we're doing blood gases, we're going to see decreased oxygen and elevated carbon dioxide. So typically our pediatric clients will go into respiratory failure before they go into cardiac failure. So if we can catch and correct their respiratory failure, then we can prevent that cardiac failure sometimes. So as we're looking through conditions, the first one is asthma. We know that's a reactive airway disease that's typically chronic inflammation. So our airways get swollen, we get congested, our airways constrict. So the bronchi and the bronchioles, those smaller airways, are going to constrict. And we see air trapping in our alveoli. So those tiny sacs that do the gas exchange at the end of our airways, they get full of air. So they have a hard time with the gas exchange portion. So we have different causes of asthma, whether it be genetics, airway infections, environments, allergies, physical activity, weather changes. All of those things can cause these asthma exacerbations. We know that patients that have been exposed to secondhand smoke are at high risk for asthma, or if you are a smoker yourself, you're at risk for asthma. If they've had previous allergic reactions, we can have that airway edema again. Family history, this can be carried on through generations. Obesity, again, we've got that high risk factor for airway occlusion, and males tend to be more at risk. The complications that we're looking for: impaired gas exchange, respiratory distress, cardiac distress. Sometimes pets can be a cause for allergy exacerbations, or if there's other allergens in the home environment, carpet is a big one. If there's pet dander or dust that gets trapped in that carpet, it can cause asthma issues. They tend to have a tight cough. They're not able to cough anything up, but it's really, really tight in their chest. They're going to have wheezing, coarse breath sounds, rails and crackles. Their chest diameter enlarges late on. So we're working so hard to breathe, and our lungs are constantly working hard to expand and not fully retracting. So that causes our chest diameter to enlarge. And like we talked about class, this is the leading cause of school absenteeism and hospitalizations and ER visits in our pediatric patients. So, which of the following should not be included in the care plan of a child with asthma? Monitoring their respiratory status and oxygenation, administering breathing treatments, maintaining strict bed rest, providing supplemental oxygen, or teaching parents the home treatment plan. Obviously, that is strict bed rest. We want them to be moving around and being active like normal to be able to prevent pneumonia and atelectasis. In our patients with cystic fibrosis, they have that autosomal recessive disease that causes our exocrine glands to not function well. So it's caused by a gene mutation that affects our protein regulation of sodium. It makes really thick secretions that obstruct our vital structures. So you'll see it touches every little body system that we have. So our risk factors are going to be family history or being Caucasian or Northern European. Complications are going to be lung insufficiency, which is going to be our leading issue, pancreatic insufficiency, losing sodium and chloride in our sweat, biliary obstructions, and then a dysfunctional reproductive system. So these patients typically or sometimes will present with a meconium ileus at birth. That's a classic sign of cystic fibrosis, but they will have frequent respiratory infections. They'll be really congested. When you're looking at their stools, they're foul-smelling, bulky stools. When you see the word steatorrhea, that means all of the fat that they're unable to digest gets excreted in their stools. So they're really greasy, bulky, frothy, gross stools. They have a really hard time maintaining weight and growing appropriately. And because they lose all of their sodium in their sweat, they actually have a salty taste to their skin surface. Later on in the disease process, you see cyanosis, clubbing of the fingers, congestive heart failure as well. So what do we do for these patients? Well, obviously, we're going to monitor their respiratory status, keeping them free from respiratory infections in particular. To help with their nutritional status, we're going to give them pancreatic enzymes. So those come in a little capsule, and it's full of these little micro or teeny tiny little beads. So you just open up that capsule and then sprinkle those little beads into either applesauce or rice cereal for our infants, or you can just sprinkle it on top of an older child's regular meal. That's going to help them to have that increase in the number of enzymes to break down their food. So because their own natural pancreatic enzymes don't make it into their GI system, we're going to add some supplemental to increase their ability to break down their food. We also know these patients don't absorb fat well, so they need vitamins A, D, E, and K in a water-soluble form so that they're able to digest those. Oxygen and nebulizer treatments are going to be helpful in maintaining that good respiratory status. We want to make sure that those are effective. And then we are going to be teaching them percussion and postural drainage. So we can either do hand percussion with a little cup, or we can set them up with a cystic fibrosis vest that vibrates their whole chest cavity at once. To be able to loosen up those secretions and break them up so that when we do those postural drainage techniques, we're going to be moving them around in different positions so that it's easier to cough out those thick secretions that we just broke up. Their diet also requires them to have high calories, high protein, moderate fat and carbohydrates. Sorry, there's a typo there. so that we get the best chance for digestion. So they require 150% of the normal caloric intake of a child just to maintain that growth and development. So if they don't digest fat very well, we're going to rely on protein as our source of energy, very high calories. Carbohydrates can cause an increase in our CO2 drive, so we want to avoid those. And then just like with any patient, we want to make sure that we are providing those age-appropriate activities. Anytime we are giving oxygen, we want to make sure that we're using an age-appropriate method of administration. So sometimes for infants, they will be more receptive to an oxygen hood. So it's just this clear plastic box that goes over their head that provides free-flowing oxygen inside of that box. It's less invasive, so it's sometimes preferred for them. Also gives you an opportunity to provide humidity within that box too, if you need to. For nasal prongs, make sure they are the right size for your patient. They're going to be used in pediatrics for low to moderate concentrations of oxygen. And then just like that oxygen hood, we have tents that we can put over a patient's head so that we can provide both mist and oxygen. With those, if we're providing humidity, it's really important that we keep a close eye on the patient's temperature and that we keep the edges of those tents tucked in and trying to keep that child dry. So as we've got humidity floating around with that mist inside the tent, as that water accumulates, those droplets are going to start falling on the patient. As they get wet, their temperature is going to drop just because of the environment. So making sure we're monitoring their temperature and keeping them dry. Obviously, if the edges aren't tucked in, then all of our humidity and oxygen will escape and not make it to our patient. As we are measuring oxygenation, we're going to use our pulse oximeter. So it tells us about the arterial hemoglobin that's moving through the body. So for the HESI, they would like pediatric patients to be satting above 95. Anytime we see a patient below 95, then we need to be aware of them. That is different than what your textbook has told you. And then make sure you know the normals for your blood gases. So typically we're going to do an arterial sample and we want to see our oxygen between 83 and 100 and our carbon dioxide between 35 to 45 for infants and children. Moving into another respiratory disorder is epiglottitis. So this is a severe life-threatening infection in our epiglottis caused by Haemophilus influenza, typically type B. The risk factors are going to be that impaired immune system and lacking adequate vaccinations. So if we're not protected against Haemophilus influenza, then we can be at risk for this epiglottitis. Complications are going to be those airway obstructions. So it progresses very rapidly. Patients are restless. They have a high fever, sore throat, difficulty swallowing or coughing because of that swelling above their vocal cords. They can't swallow their secretions, so they'll be drooling. They may have a muffled voice, and they are going to want to be sitting upright with that mouth hanging wide open so that all of those secretions can just drool right out. So those are going to be those cardinal symptoms that we are looking for, that tripod position, not being able to breathe, that drooling. That's going to be our cardinal symptoms of epiglottitis. So what do we do for these patients? Well, we can prevent this from happening by giving the HESI vaccine, prevents contracting Haemophilus influenza. We want to keep these patients upright, and we are going to prepare for either intubation or a tracheostomy. So before we do anything with this patient that could cause them to be irritated and cry, or before we look in their throat, we want to make sure that we have those advanced airways ready to go. because doing those actions can cause laryngospasm and we would lose our airway. So once we've got an established airway, then we're going to give antibiotics. They are likely going to go to the intensive care unit. We might need to sedate them while they're intubated. We might have to do restraints depending on how active they are. We want to keep them calm as much as possible so that they can relax and breathe effectively. Next is going to be bronchiolitis. It's going to be a viral infection of our bronchioles, which are smaller airways, characterized by thick secretions. So it's usually caused by RSV and found to be readily transmitted by close contact with somebody either in the hospital or family or another child that's been exposed. So really easy for it to be transmitted, especially in the hospital setting. The kids most at risk are going to be our young infants, and we are watching for complications like dehydration and severe respiratory failure. So what do these patients look like? They're going to have a history of upper respiratory symptoms. They're going to be irritable, coughing, not wanting to eat, congested, nasal flaring. They have a long breathing out phase. So they take long breaths out, short breaths in. We can hear wheezing and rales when we listen. And those shallow respirations are going to be indicating that they are getting worse. So these patients need to be in isolation. They're going to be on contact precautions. And we want meticulous hand washing so that we are making sure we're not spreading this around the hospital. Keeping a close eye on their respiratory status, especially their oxygen. We're going to help them with their airway secretions, with suctioning, maintaining their hydration with IV fluids until their respiratory status is more stable. Sometimes we can give antiviral agents to help with this if it's caused by RSV, and other respiratory treatments to help support them and the symptoms that they're experiencing. We do have a vaccine that we can give that provides passive immunity in our high-risk population. So anybody under 2 with a history of prematurity, lung disease, or heart disease. And our priority nursing action for patients with bronchiolitis is going to be maintaining that patent airway. Moving on to those ear infections, also with that respiratory system, our otitis media is going to be that middle ear infection. Because our anatomic structure is different in the young child, makes them more at risk for ear infections. We know it's closely connected to our sinuses, and it makes a great transportation system for bacteria and mucus into our ears directly. So risk factors are going to be our age, daycare setting where we're exposed to lots of germs. Breastfeeding does decrease the risk of ear infections just because of positioning the antibodies that we get from mom. Exposure to tobacco smoke, pacifier use, genetics, socioeconomic status, sleeping positions are all going to be risk factors. And we know if we have untreated or recurrent ear infections, then we have a risk of hearing loss. So that would be conductive hearing loss. So these patients present with fever. They may be pulling on their ear as an indication that they have pain. And large lymph nodes. If the eardrum is ruptured, then we may see an actual discharge from the ear. They'll have upper respiratory symptoms and may have vomiting and diarrhea associated with it. So what do we do for these patients? Well, they're going to be on 10 days of typically oral amoxicillin, making sure that they take the entire course of antibiotics so we completely eradicate the infection. We want to reduce their body temperature to normal. If it gets too high, we have that risk of seizures. So we're going to use tepid baths which is lukewarm water. We don't want to use cold water, ice, or rubbing alcohol that can bring our temperature down too quickly. For fever management, we can also use acetaminophen to help lower that fever. We're going to lay them on their affected side to help alleviate that pressure in the ear. We can also use warm compresses to help with swelling and pain management. And then reinforcing that teaching plan for home care. So they're finishing all their antibiotics, they're coming to their follow-up visits, we're monitoring their hearing, making sure we're catching hearing loss early on, and then that preventative care. So not being exposed to tobacco smoke, not feeding or bottle feeding in that supine position. So if we're laying on our back, then it's really easy for that liquid to pool and go into our ear canal there. With tonsillitis, we've got inflammation of our tonsils caused by either a virus, a bacteria, or a strep infection. So obviously, again, the younger you are, the higher risk. Daycare has those exposures to big pathogens that can cause infection, new germs that we're not immune to yet, the time of year, and exposure to tobacco smoke. So one of those, or two of the complications of tonsillitis are going to be acute glomerulonephritis and rheumatic heart disease. So if we have that strep infection that's causing our tonsillitis, we know that is the cause of that glomerulonephritis and our rheumatic heart disease. So we can do a rapid strep test, although that does have a high rate of false negatives. We can also do a throat culture, so we know exactly what pathogen is causing our tonsillitis. These patients have a sore throat, fever. They will have swollen tonsils. You might even be able to see purulent drainage when you look at them. And you may see obstructed breathing. So their tonsils are so swollen that they are actually touching, or we call it kissing tonsils, because they actually meet and obstruct that throat. Before we do this child's tonsillectomy, we want to make sure that they don't have a family history of bleeding, and we want to make sure we do a PT and PTT to make sure we know about any potential bleeding disorders before we go and do surgery in the throat, where it's really difficult to assess for bleeding. So nursing interventions, if we have a throat culture ordered, then we're going to collect that so we can target our antibiotics. Things we can do at home to help us feel better. We can do warm saline gargles, ice chips, those ice collars over our throat to help with pain management, making sure they take their antibiotics and managing that fever with Tylenol. After surgery, we're going to provide that post-op teaching. How do we know if we have post-op bleeding? Well, we're going to see frequent swallowing, vomiting, fresh blood, or trying to clear our throat. So really important that we avoid milk products that can coat our throat and cause us to want to clear. And we don't have anything to drink that is red or purple that could mask those signs of bleeding. So we're going to start with that clear liquid diet after surgery and then encourage soft foods afterwards. We don't want to use straws that could further irritate that area. And then the highest risk for hemorrhage after surgery is the first 24 hours, and then 5 to 10 days after, when we start getting back into that normal activity. So that is it for our respiratory review. We're going to move on to our cardiac disorders. So congenital heart diseases are going to be anomalies that happen while we're still in utero or shortly after birth. They happen in 4 to 10 children per 1,000 live births. We have 2 different kinds of disorders. We have acyanotic disorders, where you stay nice and pink even though you have a disorder. So these cause left to right shunts or increased pulmonary blood flow, and they tend to be obstructive defects. Our other type is cyanotic, or conditions that turn you blue. So this is a right to left shunt and causes decreased pulmonary blood flow or mixed blood flow. So with acyanotic or pink disorders, we've got abnormal circulation where all blood entering our systemic circulation is oxygenated. So everything that goes into our system has oxygen in it. Other ones are our cyanotic disorders have unoxygenated blood entering our systemic circulation, which is why we're turning blue. So we're not getting oxygen into our bloodstream flowing through our body. With cyanotic heart disorders, it is common for these patients to have polycythemia or high red blood cell counts. Because our body is trying to carry more oxygen to our systemic circulation, we're going to increase the number of red blood cells so that hopefully each one of them can carry a little bit more oxygen. And then once we've classified them in acyanotic or cyanotic, then we look at what it does to our hemodynamic status, or what does it do to our blood pressures. So we have disorders that increase the blood flow to our lungs, obstructive defects, and ones that decrease our blood flow to our lungs. And then we have mixed defects, where we're getting that mixed oxygenated and deoxygenated blood going to our systemic circulation. So let's look at some of these. So the first one is a ventricular septal defect. So you can see right here, we have a hole between our ventricles, or our lower two chambers of our heart. So this allows oxygenated blood from our left ventricle to go backwards into our right ventricle and be recirculated to our lungs. If this defect is particularly large, then it will require a surgical closure. An atrial septal defect is the exact same thing. The septal defect just means there's a hole in the wall. This one just happens to be located in our atria, or our upper chambers of our heart. So it happens to be located right behind this pulmonary artery is where we're seeing this septal defect in this particular picture. And our blood from our left atrium is going into our right atrium and then back into our lungs. So most of the time, these children can function like this without a ton of side effects. We do like to have these closed before they reach school age, so we don't end up with cardiac dysrhythmias or heart failure later on in life. So how do I keep ASDs and VSDs straight, since they're the same disorder? ASDs, your A points up, so it's talking about the upper chambers of your heart. For a VSD, your V points down, so we're talking about the lower chambers of your heart. So that's how I keep those two straight. Next up is going to be patent ductus arteriosus. So we have this abnormal connection between our aorta and our pulmonary artery. This is part of normal fetal circulation, and it should close within 72 hours after birth, all on its own without intervention. The problem comes in where it stays open after those 72 hours, and we have oxygenated blood from our aorta going back into the pulmonary artery. Typically, we can hear this when we listen to the chest. We can hear a machine-like murmur. So we hear that blood flow in that abnormal direction. We treat this with indomethacin, or we can do surgical closure. So we can tie it off with a suture, or we can stick a little plug in here to block this abnormal connection off so that we eliminate that incorrect flow of blood. With a coarctation of our aorta, we get a narrowing. So normally our aorta would be nice and wide through here, but here we have this kink in our garden hose. So we typically see this around the aortic valve, near where that patent ductus arteriosus would have been. So these patients will present with hypertension in their upper extremities and decreased or absent pulses in their lower extremities. So we detect this by doing those 4 extremity blood pressures. And this requires a surgical correction. With aortic stenosis, we are going to have thickening and narrowing of this aortic valve. So we're going to have a hard time getting our oxygenated blood from our left ventricle out through our aorta into our systemic circulation. So these patients are going to exhibit very low cardiac output. And again, if it's significant enough that it's causing symptoms, we're going to correct this with surgery, opening up that thickened or narrowed area. Our next disorder is tetralogy of Fallot, and this is a 4-in-1 disorder. So we have 4 things going on at the same time that's causing all of our symptoms. So the first thing we want to look at is this pulmonic valve. So our pulmonic valve is very thickened. So we have pulmonary stenosis here. So it's going to prevent our right ventricle from being able to easily push blood into our pulmonary artery. Because it is working so hard to push blood against this narrow, thickened valve, it's going to get really big and beefy. So we see this enlarged right ventricle, which you don't see very well in this picture, but it will actually enlarge quite a bit. So it looks like a right angle here instead of this nice curvature. So that right ventricular hypertrophy, we've overworked that muscle. It's gotten huge and strong, and it pushes really, really hard now to get that blood through that pulmonic valve. And we also have this VSD here, so that separation in the wall in our ventricles. So because our right ventricle is so big and beefy now, and it's huge with all of its muscle, it's going to easily push blood across that ventricular septal defect. So we're going to get unoxygenated blood into our oxygenated blood here. The last part of this is going to be an overriding aorta. So normally our aorta would only get blood from our left ventricle, but because we have this big VSD here, it's really easy for that aorta to end up with blood from both ventricles. So what's going into our systemic circulation is a combination of unoxygenated and oxygenated blood. So we've got blue blood and we've got red blood, which means we've got purple blood going into our body. With our right ventricle being so strong, it's very possible that if it's pumping really hard, that we're going to get more blue blood than red blood going into our systemic circulation. So we can see these patients having TET spells or hypoxic episodes because they've got more blue blood going into their systemic circulation than they have red blood. So the way that we alleviate these TET spells is by putting that child in a squatting or knee chest position. So by doing that, we increase the blood flow back to the heart so that we can get more oxygen through our circulation. We also are going to decrease that effort that our right ventricle is putting out. And these patients will have multiple surgeries to correct this disorder. Truncus arteriosus. So this is where our pulmonary artery and our aorta don't separate. So normally we would have one structure here. We would have this structure would be going over top, where we would have 2 completely separate structures. So with truncus arteriosus, think of just a really big aorta. So we've got one main vessel that receives blood from both ventricles here. So that blood's going to mix in the pulmonary artery aorta combination here. And that's going to cause that same combination that we saw with our tetralogy. We have blue blood and red blood going out into our systemic circulation. So the more pulmonary resistance we have in what little part of our pulmonary artery that we have there, that's going to increase our cyanosis. So we're going to get more blue with the more pressure in our pulmonary artery. It's going to allow more of that blue blood to get in there. Again, this one requires surgical correction. And the only way these patients survive at birth is if they have this nice VSD. Last one is going to be transposition of the great vessels. So in this case, our pulmonary artery and our aorta are flip-flopped. So our pulmonary artery should be attached to our right ventricle, and our aorta should be attached to our left ventricle. But you see here that they are reversed. We also have this PDA here that allows that connection between the two. So unless we have that PDA, a VSD, or an ASD, we are incompatible with life. So we need that connection to allow that mixing of blood to allow us to survive long enough for surgery. So obviously this is a medical emergency. And because we need to kind of reverse the flow of blood here, we need this PDA to stay open so that we can get some of this red oxygenated blood to travel through the abnormal pulmonary artery, and some of it will trickle into our aorta to get out to the rest of our body. So it's so critical these patients have that PDA so that we can get some oxygenated blood to our systemic circulation. So when we put these patients on prostaglandin E or PGE to keep that PDA from closing. So that's our transposition. We're flip-flopped here. With hypoplastic left heart syndrome, sorry, there's one more. This is where our left ventricle is really small, so it's underdeveloped, and this causes oxygenated blood to enter the systemic circulation through that patent ductus arteriosus. This is another one that we keep them on prostaglandins to keep that PDA open so that we get oxygenated blood to our body there. So these patients will need multiple surgeries, again, to correct that underdevelopment. So when we're looking at cardiac disorders, what are those signs and symptoms of a congenital heart disease? Well, we're going to see irregular rate, rhythm, heart sounds, blood pressures are going to be different. We might hear murmurs. We might see cyanosis or a clubbing of the fingers after two. They're going to have a hard time eating, gaining weight. They're going to present as failure to thrive. They might vomit a lot, have frequent respiratory infections, especially if we have increased blood flow to our lungs. They're not going to tolerate activity. They're going to fatigue very, very easily. Even something as simple as bottle feeding can exhaust them. And a lot of times there's a history of maternal infection during pregnancy that caused the congenital heart disease. So the two main tests that we do to diagnose these congenital heart diseases are electrocardiograms or an ECG, and that looks at the electrical rhythm of the heart. So that's what gives you your telemetry strip or that rhythm that you see on your monitor. The other most common diagnostic test is going to be an echocardiogram. So that's your ultrasound of your heart. And that is going to use sound waves to give you a picture of your structure. And we can also trace blood flow with these. So we can watch the blood flow so we can actually visualize the murmurs that you see. And remember those normal cardiac rates in children that we covered at the beginning. They're also in table 5.3 in your HESI review book. And also remember with heart rates that it increases when our child is crying or having a fever. So we want to keep that in mind when we're evaluating an elevated heart rate. So how do we care for these kids? Nutrition is going to be extremely important for them. Remember, they fatigue very easily. So we need small, frequent meals of high calorie formula or fortified breast milk. Sometimes these infants need tube feedings so that they can just rest and conserve their energy. Even if they have a tube feeding, they need a pacifier while they're being fed through that nasogastric tube or that G tube, so that they can promote that sucking reflex, those oral skills. We want to maintain their hydration status. Remember, if they have a cyanotic defect, they tend to produce more red blood cells. So we have high risk for clots here. We want to keep their temperature normal. We don't want to put extra stress on the heart by having them be too hot and elevating that heart rate. We also don't want to stress their respiratory system by making them too cold. They will need frequent rest periods, making sure they have long periods of undisturbed sleep so that they can maximize their energy. Sometimes we'll be giving digoxin or diuretics. So we've got special considerations for those, like heart rate, urine output, monitoring for deterioration, and then working on that home teaching plan, especially with prophylactic antibiotics. So we need antibiotics before any dental or invasive procedure so that we don't end up with endocarditis or infection in our heart. So patients will need to be on antibiotics even if they don't have an infection as a preventative measure. When we take patients to cardiac catheterization, we want to be monitoring for changes in their heart rhythm from that catheter being in their blood vessels, potentially irritating the heart, any bleeding, perforation, phlebitis, an arterial obstruction where we went in, whether that be through the groin, through the neck, through the wrist. They will go to the ICU immediately after that cardiac cath. So we want to prepare parents for what they're going to see in the ICU. Is their child going to have a chest tube? How many IVs are they going to have? What are their dressings going to look like? What equipment are we going to see? Are they still going to be intubated and on a ventilator? Making sure they understand the visiting hour rules and how many people are allowed at the bedside, where family can wait during the procedure while their child's in surgery. A lot of times visualization is really helpful. So using a doll or drawings to help parents understand what it is that we're doing. After catheterization, we want to monitor vital signs, pulses. We're watching that incision site for bleeding, looking at their cardiac rhythm. Again, we had a foreign object in our blood vessels. So we want to make sure that we're not seeing any irritation there. And then their positioning and activity restrictions. So they have to stay flat immediately after cardiac cath. And they typically have a weight that goes over top of that insertion site so that we can apply pressure there and help with clotting. They'll be on strict bed rest for a while so that we ensure that incision or that entry site heals completely before we allow them moving around. With heart failure, it's where our heart is not able to pump out the blood that is presented to it. We see it most often with those acyanotic or pink defects. We can see it with cardiac hypertrophy, cardiac valve disease, arrhythmias. Chronic lung disease can also cause heart failure. We're not getting enough oxygen through our body, so our heart is going to suffer as well. Viral infections and then prolonged hypertension are causing our heart to have to work harder, so it's going to fatigue a lot easier. Those risk factors are going to be hypertension, obesity, sedentary lifestyle, and tobacco exposure. Complications, poor growth and development, pulmonary hypertension, arrhythmias, blood clots, kidney and liver damage, and anemia. How do these patients present? Well, they have tachypnea, shortness of breath, tachycardia, fatiguing very easily, so they're going to have difficulty feeding. We also see cyanosis, those signs of pulmonary congestion, that grunting, wheezing. We're going to see swelling, especially in the eyes and the face, weight gain. because our heart's not pumping effectively. Sweating, hepatomegaly, that enlarged liver. How do we care for these patients? Watching their vital signs, monitoring those signs of cardiac distress, respiratory distress, keeping our head of the bed elevated, using gravity in our favor, giving supplemental oxygen, digoxin, and diuretics to alleviate that edema, increasing the pumping capacity of our heart, the effectiveness of that pump. We are going to be doing at least daily weights, if not weighing an infant every shift, so that we can see those weight fluctuations, making sure that we report any unusual weight gains. They'll be on strict INO, so if you have an infant in a diaper, you're going to be doing diaper weights on them. They need a low sodium diet of either formula or breast milk if they're an infant, but we want to prevent that fluid retention, so low sodium. These patients too may need gavage feeding if they're too fatigued to carry out NPO feeding. And then when we're doing those daily weights, we want to make sure that they are on the same scale and the same time of day so that we get the most accurate comparison. So with digoxin, we have to take an apical pulse for a full minute to assess for bradycardia. We know digoxin can hold or can cause bradycardia, so we're going to hold our dose if our heart rate is below normal. We are going to make sure that we're double checking our dose before we're giving it, and we're going to be checking our blood levels frequently to make sure that we maintain that therapeutic level. Parents are able to give digoxin at home, so we need to teach them how to do it safely. They have to give it consistently. We don't double up if we miss a dose. We never skip doses unless a physician tells us to. And ideally, we are giving it an hour before or 2 hours after meals. So we want that empty stomach. We don't want to mix it in with formula or food. Just like we do in the hospital, we need that good pulse assessment before we administer digoxin. We need to know when to hold it, when to call in, and notify the physician. And obviously keep it in a safe place out of reach of children in general, whether it be that patient or siblings. We don't want anybody to get into that and have poisoning. We also need to teach parents the signs of digoxin toxicity. An infant is not going to be able to tell you when they don't feel well or they're nauseous. So vomiting is going to be your earliest sign of toxicity, which a lot of times we mistake for the infant just spitting up, like this is a normal feeding response. So looking for those other GI symptoms, anorexia, diarrhea, abdominal pain. Those are going to be your earlier warning symptoms. Later on, we're going to see those neurologic symptoms like fatigue, muscle weakness, drowsiness. And if our potassium levels are low and we have hypokalemia, we can have increased digoxin toxicity. So the antidote for digoxin is actually vitamin K. So replacing that potassium. Next, we're going to talk about rheumatic fever, and we know that that is an inflammatory disease. It's the most common cause of acquired heart disease in pediatric patients. It affects our aortic and mitral valves, and we know that cause is from that untreated strep throat infection. So that beta hemolytic strep infection. Risk factors are family history, obviously having that strep throat infection, overcrowding where you're exposed to more pathogens. Those complications are going to be the heart vessel disorders, that mitral valve damage that happens. We can have joint swelling and joint pain, also nodules under our skin in that subcutaneous tissue. So how do we diagnose rheumatic fever? We can look at our erythromycin sedimentation rate or our anti-streptolysin O titer. So both of those will be elevated. Those are going to be inflammation markers. Our patients present with chest pain, shortness of breath, tachycardia, joint pain, chorea, which are irregular, involuntary movements. They have a rash over their trunk, and then those nodules over those bony prominences. So underneath their skin there, over those bony prominences, they'll have these little fatty nodules. And also a fever. So we're monitoring their vitals, looking for cardiac distress. They will be on bed rest. While they have a fever, they're going to need help with ambulation with that joint pain and swelling. Those involuntary purposeless movements are going to be temporary, so they will go away as that child gets better. We're going to be giving medications to get rid of that strep infection and then prevent it from coming back. So typically we give penicillin. If they have a penicillin allergy, then we might give erythromycin. We're also going to be using aspirin for its anticoagulant properties. So making sure that we don't end up with blood clots in those weakened blood vessels, also helping reduce that swelling in the joints that we're seeing. They are going to be on penicillin for 5 whole years. So we're going to give it either IM or IV in the hospital. And then once they go home, they'll likely be just on oral penicillin. So we're going to give it long-term, very slowly, so that we get that sustained level to prevent that strep throat infection coming back. We want to make sure that we have emergency equipment available when we're administering any new medication. Making sure we don't have an allergy to penicillin or a cephalosporin. And then making sure our dentists and healthcare providers are aware so that we know whether or not we need additional prophylactic antibiotics on top of that penicillin before a procedure. Next is Kawasaki's disease. So this is systemic vasculitis. So we get weakened vessels, especially our coronary arteries that supply our blood flow to our heart. We don't know the cause of Kawasaki's disease. It typically presents after a patient has a viral illness, and we have a very high fever that doesn't respond to antibiotics. Happens more often in our kids under 5, and we can end up with permanent heart damage because of those aneurysms. So in that acute phase, we've got that high fever for more than 5 days. These are where those signs and symptoms come in that are very classic. We've got conjunctival redness, so pink eye looks like a strawberry tongue. The surface of your tongue looks like a strawberry. Red, swollen hands and feet, and we can have cracked skin where we're really irritable as well. That cracked skin comes in our subacute phase. So extremely irritable during that acute phase. We feel horrible. We feel miserable. That subacute phase, we start having peeling in our hands and our feet and our skin folds. And then the convalescent phase is when all of those signs are absent until our labs have returned back to normal. So we might not be symptomatic, but we still have abnormal labs. So we treat these patients with IV immunoglobulin. We can treat those high fevers with Tylenol, monitoring their cardiac status through their eyes, nose, and daily weights. We can help with that cracking of the skin with lotions and cool compresses. And we're going to do meticulous mouth care, promoting clear liquids and soft foods during that time where they're not feeling well, and then helping the parents with comfort during those irritable periods, and then home care teaching. So that will do it for our respiratory and cardiac disorders.